Okay. Thank you everyone for joining us today. I am Lindsay Green, Coordinated Care. And with collaboration from all of the MCOs, we are excited to bring you this webinar during the hour on the Behavioral Healthcare Continuum for youth with Apple Health coverage. I will be your host today. So if you're having any tech challenges or any kind of issues that I can help you with, feel free to message me in the chat. And our plan is to save some time for questions and answers at the end. So as we go through today's webinar, if you do have any questions that come up, you can put them in the Q&A box or in the chat box, and we will get to as many questions as we can at the end. A recording of the webinar will be available after. We'll send that out through an email link, and then also the recording will be uploaded to the AWIP YouTube channel as well. So be on the lookout for that if you're not able to stay for the whole time. And in addition, following today's webinar, evaluation will automatically launch when you leave Zoom. We would really appreciate it if you would take a moment to give us some feedback and let us know how we did, and also give us some feedback about presentations or training content that you are looking for in the future as well. So I think those are all of our announcements, and now I am excited to welcome our presenters today. So we have Dr. Terry Lee from CHPW, Libby Hine from Molina, Amanda McClendon from Coordinated Care, and Kate Nesseth from United. And first up, we have Dr. Lee. So I'm going to turn it over to you and go ahead and launch our PowerPoint for today.
Thanks, Lindsay. So on the next slide, we have our learning objectives. So this is a presentation focusing on the Washington State Medicaid plan on the behavioral health continuum of care. So this is like a behavioral health services 101. This will go over the range of services that are available and how to access. So if you feel you have a very good understanding of the continuum of care, you may want to wait for our Behavioral Health 201 presentation. But if you want to learn about the system or learn about other parts of the system that you're not working on, I'd encourage you to stay. Next slide, please. So here's a very simplified depiction of the continuum of care. This isn't a linear continuum, really. People can progress and jump steps, but kind of on the left, you have outpatient mental health and SED services, and then on the right you have the more intensive services. So you have like acute mental health on the right, and then more like long-term intensive services in residential treatment. We're going to go over the individual services, but this is just to give you an idea again of the range. Next slide, please. In talking about services, and especially for children, it's important to understand the concept of least restrictive setting. The idea would be that we want people to really benefit from treatment in their natural environment if possible. And we should only restrict people, including youth, if it's needed. So for children especially, we want to keep them on a typical developmental trajectory. We could talk about what that is, but if we want the kid to live with other kids, play with other kids, best thing is to treat them while they're doing those other things. When you treat in someone's natural environment, the changes are more likely to sustain. That's because you're not, again, artificially removing a kid from, say, substances and then putting back in an environment with substances and then trying to learn new skills to deal with it. You'd want, in the case of substance use, to treat a kid and then where they have to develop skills to say no, to stay away from substances, for instance. Also, treatment, it can be actually very therapeutic to socialize with pro-social peers. So again, just using substance use disorder as an example, if you hang out with kids who think using substances is a bad idea, then you're much more likely to stay away from substances. On the other hand, say if you have an eating disorder and you're around kids all day who have eating disorders, that might make you think about eating disorders, or thinking about what you're eating, what your body looks like. If there's a lot of talk around that, and there is a need for that type of treatment, but if possible, if instead you were being treated for an eating disorder and you were around other kids that talked about being healthy, working on well-being, sports, eating to support physical activity, that by itself would protect against an eating disorder as well as help treat the eating disorder. Next slide, please. So with this, I'll turn it over to Amanda.
Thanks, Dr. Lee. And again, welcome everyone. Thank you so much for joining us this afternoon. Now we're going to start diving a little bit deeper into the services that are available through Medicaid and covered by MCOs. So this slide represents some of the outpatient mental health services that we're able to cover as MCOs. Assessment, psychiatric evaluations, so kind of that initial phase of a member getting into services potentially, or possibly getting a reassessment to determine if there's still a need. Individual treatment services, including school-based, medication management and monitoring, crisis services, group therapy, peer supports, brief interventions, family treatment, and school-based services. Next slide, please. Now we jump into a little bit more about substance use disorder. Treatments available through the MCOs, very similar to the mental health services. MCOs cover SUD assessments, brief intervention, withdrawal management, outpatient therapies, intensive outpatient therapy, also known as IOP, and residential treatment for SUD. Also included are medication-assisted treatment, also known as MAT, and opiate substitution treatment, case management, and peer support. I would like to now introduce you to Liddy Hine from Molina for the next slide.
Thank you, Amanda. Hopefully all my mute buttons are off. So thank you all for coming out today and just taking the time to meet with us. We know you're really busy and really are excited to share this information with you today. I'm going to talk a little bit about a very specific treatment called applied behavioral analysis. Really, it's a specific evidence-based treatment that is designed to really improve behavior or skills related to core impairments really associated with autism or other developmental disabilities. There's a significant focus on understanding the behavior through observation and assessment, with the goal of increasing behaviors that are beneficial and decreasing behaviors that do not benefit the youth. It can help to increase language and communication skills, improve attention focus, build needed skills, and decrease problematic behaviors. Next slide, please. So for additional information on this, specifically, in our state, applied behavioral analysis has some specific referral requirements. And I want to really clarify here, this is specifically for referral into ABA services, not necessarily just for any diagnosis of autism or another developmental disability. But if you're looking to refer a youth into ABA services, there is a pathway in Washington State around referring into what they call a Centers of Excellence. And that is a designated provider that is designated by the healthcare authority, or it is a specific licensed provider who is already trained in really providing assessment and diagnosis, such as a developmental pediatrician, a neurologist, a pediatric neurologist, pediatric psychiatrist, or psychologist. So they must conduct a comprehensive diagnosis evaluation, and included in that is a written order for ABA. So really ensuring that that there is a really defined written order that says what kind of targeted behaviors they're looking at improving through this treatment. It must meet medical necessity, as all services for Medicaid need to. And in Washington State, it's a little unique in that ABA is actually provided through the physical health benefit side. Unlike in many other states, it's provided through the behavioral health benefit. So it's just for an awareness. There's kind of 3 core programs that are provided within ABA. One is called Intensive Day Support Program. You might hear it as Day Support Program, Day Program. It's kind of referred to by a lot of different things. It's basically a 48-day program that is designed to provide intensive assessment and kind of a treatment plan for a youth going forward. It integrates in speech language pathology into that program, so speech therapy, and it's really a very intensive program designed basically for 48 days. There's also individual support and group support, which is often provided through community-based support, or it can be center-based support. And then there's ABA parent or caregiver training. And most recently with COVID, where a lot of youth were really struggling to get into treatment, there was a lot more focus put towards providing telehealth parent training treatment, which was really helpful. So now I'm going to introduce to you Kate Nesseth from United Healthcare, who will provide information on our state's first episode psychosis program, or otherwise known as New Journeys.
Thank you, everybody. And thrilled to be here today to pass on all this information. Look forward to some of the questions at the end. I'm going to talk about a couple wraparound programs. First episode, psychosis, is the first. It's also called New Journeys. And this has been an effort, a collaboration between Healthcare Authority, University of Washington, and WSU. It started off with a couple regions doing pilots, and now it's moving throughout the state. There's still a couple regions that do not have agencies providing the service yet. Our friend COVID has put a delay on some of that, and workforce shortage also. So, but I know HCA is working hard to contract with agencies to provide it. Let's see. It used to be only for youth and young adults, but they've extended the age all the way up to 40, which is fabulous. So anyone of that age range that has their first episode is eligible. However, they do, and also they do not need to have Medicaid. This is for any youth with any kind of insurance or no insurance. This also does not go through the MCOs. This is an HCA program, and we do not provide support around this other than to refer or to collaborate with agencies if we have our members in this program. And so as you can see, there are some specific things that the providers and agencies look for as far as eligibility. Psychotic symptoms that are not known to be caused by the temporary effects of substance use, medication, or medical condition. There's the duration here. Have any duration of untreated psychosis greater than 1 week and less than 2 years. So again, very specific. Have no more than 18 months of prior cumulative treatment with antipsychotic medication, and they fall within the program's catchment area. Next slide. Again, it's very much like wraparound. They provide case management, outreach engagement. That's a big, huge, trying to get the youth involved in treatment. There's medication management, a big emphasis on family education, peer support, primarily youth support. And what's kind of an added bonus here is a lot of work around finding employment and education for the youth or young adult or older adult now. And then the model of treatment is individual resiliency training. Next slide, please. Wraparound with intensive services, or as we call WISE, is probably more familiar to you, and we're hoping that most of you know about this program. It is a result of a lawsuit against the state due to lack of access to intensive services. Just good news, recently the settlement has been dismissed, but WISE will continue as is, and we are continuing to work on improvement and we collaborate closely with all the providers and the healthcare authority. WISE provides comprehensive outpatient behavioral health services and supports to Medicaid eligible individuals. So they do need to be receiving Medicaid up to 21 years of age. And the youth that usually are enrolled in WISE have more complex behavioral health needs or multi-system involved. And it's kind of a step up from regular outpatient services. It's a team-based approach. They do child and family teams at least once a month, if not more often. And it's expected that there is at least, 10 or more hours a month being provided for the youth and family in achieving wellness, safety, and to strengthen communities. Can you go back just really quick? Thank you. Required elements of WISE, providers need to be able to provide intensive care coordination, intensive counseling services in the home and community, wherever the youth and family are, crisis intervention and stabilization services, again, wherever the youth and family are, peer support, again, just like New Journeys is a huge piece of this, and they have youth and family peers, and medication management. Next slide. So youth with Medicaid must meet eligibility criteria. There's a screen using the Child and Adolescent Needs and Strengths tool. It's a short screen and to help determine eligibility. And there also is medical necessity required, just like every other Medicaid service. Anyone can make a referral to WISE, and here's the link to all the different providers in all the counties and all the regions in Washington. And now it goes back to Amanda.
Thanks, Kate. Now we're going to review a little bit of behavioral health crisis services. So if you have a youth who has a behavioral health provider or a WISE team in place, and they are dealing, and the member or the youth is dealing with a behavioral health crisis, contacting that youth behavioral health or WISE provider can be really helpful, as both of those servicing providers have a crisis service plan in place for the member, and they know that member. So making that contact could be very beneficial in helping the member through the crisis situation. For youth who are not yet connected to a behavioral health provider or WISE team, you can call your local regional crisis phone line. And there's a link on this slide, and you can search it on HCA's site or on the Regional Behavioral Health Administrative Service Organization for the members region. So there's multiple ways that you can get access to that contact information if you don't already have it. And anyone in Washington State, regardless of the insurance, or if they're not connected or they are connected to BH services, that regional crisis phone line is available and can be utilized. And it can be used for multiple reasons. So one being that mental health crisis services, including the dispatch of a mobile crisis outreach team, staffed by mental health professionals and certified peer counselors. And two, short-term SUD crisis services for people intoxicated or incapacitated in public. And three, application for mental health and SUD involuntary commitment statutes, which is available 24 hours a day, 7 days a week, 365 days a year, to conduct an involuntary treatment act, also known as an ITA assessment, and file the detention petition when appropriate. So who can conduct an ITA assessment? That would be a designated crisis responder, also known as a DCR. And a DCR is a mental health provider or professional designated by the county. So under RCW 71.05 and RCW 71.34, a DCR can detain a person for involuntary hospitalization when the person is gravely disabled or a threat to others due to their behavioral health disorder. So RCW 7105 is the law that kind of is over the adults, whereas the RCW 7134 is for youth ages 13 through 17. We'll talk a little bit more about ITAs in a couple of slides, but it is definitely something that is occurring on a very, it's regularly occurring with a crisis situation. Next slide, please. All right, so this map is a representation of the different BHASOs across the state, broken out into the different counties as well as regions. So you can see here, we have several different BHASOs involved in helping assist members in a crisis situation. And this is a good tool for folks to use when they're trying to figure out, especially if a member maybe is in a different county than you're used to providing services for. This is a good representation of where to kind of access those services. Next slide, please. All right, for acute mental health inpatient, so there's a couple of options here, as you can see, so voluntary and involuntary. So this is where we're going to dive a little bit deeper. So voluntary psychiatric inpatient admission is when a member is admitted voluntarily, for behavioral health reasons. So members admitted should meet medical necessity. As Libby had identified earlier, it's important that the member is receiving a particular level of care, that they're meeting the medical necessity for that level of care. So voluntary means when a member maintains their rights and can leave when they choose. Whereas when we dive a little bit more into the ITAs, when a member is ITA'd, their rights are they're revoked by the DCR. So they are being court ordered, they're being ordered to stay in that level of care to receive services for stabilization. So the member is not able to leave, and you may hear terminology around gravely disabled. So what does that mean? It's for situations with ITA. So it means a condition in which a person, as a result of a behavioral health disorder, is in danger of a serious physical harm resulting from a failure to provide for his or her essential human needs of health or safety, or manifest severe deterioration in routine functioning evidenced by repeated and escalating loss of cognitive and volatile control over his or her actions, and is not receiving such care as is essential for his or her health or safety. And then, and with ITAs, there's different levels. So with an initial detainment, it is 120 hours where the member is, they're ordered to receive the services. And if there's continued need for them to receive those services, the next stage would be a 14-day hold, and then a 90-day hold, and then a 180-day hold. Another possible admission type for acute mental health inpatient is family-initiated treatment, which will be reviewed further later in the slides. I would like to now hand the presentation back over to Dr. Lee at CHPW.
Thanks, Amanda. So I'm going to talk about secure withdrawal management and stabilization, also known as SWIMS. So in 2018, Ricky's Law established involuntary treatment for SUD treatment. This is the equivalent of involuntary treatment for mental health conditions, except Washington State didn't have this prior to 2018 for SUD. They need to meet criteria for involuntary treatment. Amanda McClendon just explained what serious harm and grave disability mean. So that those same criteria are applied, except that the problems with self-care or self-harm are due to the presence of a substance use concern. The DCRs, or designated crisis responders, the same individuals who evaluate for involuntary mental health treatment, are the ones who evaluate for involuntary substance use treatment. The initial detention is for 5 days, and a program can petition for another 14 days. I just want to highlight that kids generally experience physiologic withdrawal at much lower rates than adults, even given the same level of substance use. So for kids, the emphasis, of course, they're monitored for physiologic withdrawal, but the emphasis really is on the treatment from the beginning. Next, I'll turn this back to Libby Hine at Molina.
Thank you, Dr. Lee. I'm going to be talking a little bit about Children's Long-Term Inpatient Program, or what we know in the state as CLIP. CLIP is an intensive long-term inpatient psychiatric treatment, which is a state-ran facility. It's state-ran and operated for ages 5 to 17. I think a couple of important things to know about this is that it's not an acute access service. So typically it does take a little bit to get into CLIP, and it is designed to provide longer term intensive treatment. There are a limited number of beds in Washington State, so that is a challenge, and I know that the state is constantly working on how to access or how to address that issue. Eligibility criteria includes it must be a primary diagnosis of a severe psychiatric disorder, which is having significant impact on the youth's ability to function in the community. Usually, in most cases, other least restrictive alternatives have been tried in the community setting, although occasionally we do have youth who have a sudden and severe psychiatric onset, which requires them to go to CLIP as a first step. Their psychiatric condition requires that they have an inpatient stay. And there's two basic ways that children can access this program. One is through involuntary treatment, the ITA that Amanda was discussing earlier. The other process is voluntary. Next slide, please. So when we're looking at involuntary treatment, when a youth is detained on an ITA, they are immediately placed on the wait list for CLIP. For voluntary, though, it is a very different process in our state, and it's a little complex, so I'm hoping to put some light onto that and help folks understand this process. First of all, understanding that MCOs, all of us have what we call CLIP liaisons, and for non-Medicaid youth, the BHASO has a CLIP liaison. All of us can help to assist the family and youth in understanding CLIP, as well as how to go through the CLIP process. Each community has a CLIP liaison or a CLIP committee, which is, it basically provides a forum for the youth and the family and the CLIP liaison, either MCO or BHASO, to kind of talk about some of the challenges going on with the youth and look for least restrictive alternatives, other supports that can help the family. Typically, the youth will attend that sometimes, and sometimes they won't. They will just have the family attend. And the committee really decides kind of whether they can address the challenges within the community or whether they do recommend a CLIP application is submitted. If they recommend a CLIP application is submitted, the CLIP liaison at the MCO or BHASO will assist the family in completing the application. Oftentimes that's done in collaboration with other community providers, such as WISE providers who've been working with the youth for quite some time. And then that will get submitted to what's called the CLIP administration. The CLIP administration really reviews the application to determine medical necessity and can either approve or deny that application at that level. If the application is denied, the MCO or the BHASO liaison will assist the family in finding other supports that are more appropriate or recommended. And if it's approved, they will then help the family through the process of getting ready for CLIP treatment. And now I'm going to go back to Dr. Lee to discuss residential substance use treatment.
Thanks, Libby. So for this level of care, youth must meet the ASAM, or American Society of Addiction Medicine, 3.5 criteria. So there are voluntary options that include the youth voluntarily agreeing to go and consenting. And then there's adolescent-initiated treatment. There's also a family-initiated treatment option, and that will be discussed next. Under House Bill 2642, the first 2 days of residential SUV treatment are automatically reimbursed, and then the payers would apply medical necessity criteria. So prior authorization is not required, but a provider has the option for prior authorization. With that, I'll turn it back to Kate Nessett at United.
Thank you, Dr. Lee. So we just wanted to briefly let you know about family-initiated treatment, or FIT, which is related to the age of the consent. And you may know that age of consent in Washington for behavioral health services is 13. Several years ago, parents did requests from the legislature that they figure out a way for parents to be more involved or request treatment when adolescents were unwilling to do so. What came out of that effort was parent-initiated treatment. In the last couple of years, family-initiated treatment has replaced parent-initiated treatment. And the goals of FIT are to provide parents a way to access services when they feel a youth may need behavioral health treatment and the youth is not as willing to engage or not going to engage, and that for the providers to really work with that youth to help them show the benefits of treatment and may be more willing to provide their consent. Under FIT, parents are able to provide consent on behalf of the youth. Consent is not required. The youth would have to meet medical necessity before treatment can be initiated, however, just like every other service. It creates a process, or the FIT process creates an additional access point, but it does not guarantee care on demand. Providers will have individual processes, policies, etc., requirements for their admission process. Next slide, please. So what FIT is, it's a way for adolescents and their parents to seek out behavioral health treatment. There's up to 12 visits with an outpatient behavioral health provider for as long as 3 3-month periods. It gives providers an opportunity to meet youth where they are at and to engage them in treatment. It can last inpatient FIT can last up to 30 days, and regular reviews are conducted for all youth in outpatient and inpatient services to continually assess medical necessity. I do want to note that family-initiated treatment cannot be used for children's long-term inpatient treatment access. Next slide, thank you. What FIT is not. It's not guaranteed immediate access to behavioral health treatment services. Services beyond 3 months cannot be continued without the adolescent's consent. It does not supersede federal substance use disorder laws. Each provider's intake and assessment process may be different, and services in inpatient FIT cannot continue beyond 30 days without the adolescent's consent. Next slide. Here is a slide that we suggest you hold on to and refer to often. This is a list of mailboxes or links for each MCO if you feel that the MCO can support a youth around accessing behavioral health treatment. Just all you need to do is click on the link and be detailed in who the member is, what the needs are, how the MCO can be helpful. Next slide. And here are some resources. Here again is the referral contact list for WISE, mental health crisis lines in the state, and more treatment services fact sheets on the HCA website. The HCA website, if you put in behavioral health treatment for youth, there are many, many resources. So we really encourage you to peruse that site when you have a moment. Next slide. Okay, pass.
Okay, I think the first question that came in was in the chat. It says, what is being done to increase qualified providers or centers of excellence to diagnose autism, especially in Southwest Washington and rural areas?
Do you want me to take that one, Lindsay?
I'm just going to read them out, and
Sure.
panelists can decide who wants them.
Absolutely. Actually, there's often centers of excellence trainings that are occurring. Dr. Stobie is really in charge of that around the state, and we often receive those information about when those trainings are, and we blast those out to our networks to really through a fax blast or emails. I know all of the MCOs, we also have a website, a joint website through the Association Washington, is it AWIP, Association of Washington Health Plans. Is this right, guys? That actually we post that on to ensure that people can access that as well. I think that's to address the centers of excellence. Was there a different additional question to that, Lindsay, I think?
Yeah, there were a few more questions around centers of excellence and treatment for individuals who are diagnosed with autism. So over to the Q&A here now, and there was some discussion in the Q&A around alternative treatment for individuals who are diagnosed with autism. And so wondering if
Absolutely
covers anything other than ABA for those diagnosed with autism.
Yeah, so I think there's a lot, since we're focused on behavioral health here, but there are a lot of other treatments that are kind of under the physical health side that really are very effective for autism. Occupational therapy is often used, speech language therapy, and then there's a lot of things that are outside of the Medicaid system that are funded, or outside of the managed care system, that are funded to support youth that are either through the schools' early intervention programs or through their local Department of Health, those kinds of programs. So early intervention programs of all sorts. And additional programs like Early Head Start and ECAP have kind of a specialized focus in working with children that have developmental disabilities. So just lots of different options. And typically what we do as managed care is our care coordinators will work with a family to kind of see what they're interested in. Not everybody's interested in ABA. ABA, as you can see in the chat, is controversial a little bit for some folks. And so not every family is really interested in receiving ABA. So there are other options and resources that we can help to refer them to.
Oh, this is Terry. I just entered into the chat some information on Center of Excellence, Autism Center of Excellence trainings. The next one is December 10th, so there's still time to sign up for it. And again, the link is in the chat.
Wonderful. And I'd also like to call attention, Stephanie put a link in the chat as well to the AWIP website. So please go there and look for updates. We're pretty regularly updating training and information on that website.
Can I just, this is Kate, can I just mention something?
Yeah, go ahead.
I think we had a question on the registration spreadsheet about behavioral, positive behavioral health, positive behavioral support, and we do not provide that service. It's not a Medicaid funded service, so I just wanted to put that out there. But we do, we can refer youth to WISE if they have a mental health diagnosis, and we do serve many youth that have autism. With that care coordination, therapy, family education, etc. So again, they have to screen in, they have to have that mental health diagnosis and have Medicaid. But the WISE providers have been receiving training around autism, around ABA. They work closely with ABA providers. ABA providers are on the team. So we're getting better and better in serving those youth with WISE.
Yeah, and kind of along this same line, Libby, I think you answered a part of this question, but we might want to touch on the WISE aspect of it. The question is, how is lack of access being addressed? Wait times for ABA therapy is typically 1 year plus in my area, and WISE is 6 months plus if they are even putting youth on a wait list.
So I think we each have a little bit different, we have different case management programs and different kinds of ways that we help to help our members access these different programs. Absolutely. ABA in some areas can be really challenging, particularly in rural areas. There's a couple areas of the state where we have a lack of providers. So speaking from kind of the Molina perspective, and I'm sure other MCOs, we're constantly looking for additional ABA providers who are willing to take Medicaid youth and working with them. Also, just really looking at what other services are available while a youth is waiting to get into ABA. So exactly what I was talking about a little bit earlier, there's also ECAP or Early Head Start or other programs, because we recognize that the earlier the intervention, the research really shows the outcomes are better. And so we're doing a lot around that. Kate, do you want to talk a little bit about WISE?
Yes, I mean, I think it's the same for WISE. If there is a wait list, the youth is on a wait list, you know, we are asking our case manager, care coordinators, you know, all the MCOs are to, you know, work with the family and finding other services and supports. Unfortunately, yes, there are some regions or some providers that have lengthy lists due to workforce shortages. Again, reaching out to the MCO and letting us know that some care management or case management would be helpful for the family would be great.
Okay, so I'm also seeing some comments in the chat around wanting information around adult behavioral health supports. And so I think that's really great feedback for us. If you could put that in your evaluation when that launches at the end of today's webinar, there is a section where we ask the question, what's, you know, future webinars you'd be interested in. I really encourage you to take a moment to complete that evaluation and put that information in there for us, but we'll certainly make a note of that as well. The next question, are there any updates around the change of agencies only being able to hire already certified peer counselors?
I feel like
can you say that again, please?
Yeah. Are there any updates around the change of agencies only being able to hire already certified peer counselors?
I think that's more of a healthcare authority related question than a managed care related question. I think what they're referring to is that currently the only way that a peer certified counselor can bill is they have to complete the statewide certified counseling program or the training. And that is kind of as a consequence of that, some organizations are unable to hire by their own hiring practices until someone is able to bill. And so I think it's an individual organization thing, but it certainly is something that I know we as managed care and others have been in conversations with the healthcare authority on trying to work on what we can do to improve that. I think it's more of a Medicaid rule that has created this issue.
Okay, and I'm also seeing some questions coming up around first episode psychosis. So the questions around, is a referral needed by a provider for the FEP program, and are there plans to expand it to Snohomish and the North Sound area?
This is Kate. Anybody can refer. So anybody, the youth, the family, provider, a neighbor, it's kind of similar to WISE. Anybody can make a referral. And then, you know, the provider needs to respond and contact the youth. So that's one. And yes, there, again, like I mentioned, the effort to expand into regions or counties where there are no services at this point has been delayed because of COVID. But I know North Sound has been very much wanting the program. I've been in communication with HCA about timeline because we have a lot of youth up there. All of us do. It's a huge area. And so there's a lot of members up there, and but they've just not been able to be able to get it implemented yet in those regions. This last couple of years have not been helpful, but they're working on it.
Yeah, thanks, Kate. And the next question is, who is the provider in Washington State that provides day program services?
So for ABA day program, there's multiple providers that actually provide that service around the state. And so we can put a link to that. I'll have to pull it up and see if I can find a statewide link. Otherwise, we as MCOs each have our pods or provider directories or whatever we call them, where you can go on and actually see which providers provide ABA services and what type of services they provide within the region.
Thank you. And then the next question is on CLIP. What is the typical weight for a CLIP bed?
You know, that varies during different times, to be honest with you. With COVID, it's been really challenging. So I would say around usually 6 months, 3 to 6 months is the average wait time for CLIP, but it can vary. Sometimes youth get right in and other times it can take a little bit longer. During COVID, we saw a lot less kind of transition happening for safety reasons, and so there were longer wait times.
There is a new cottage that opened up at Child Study and Treatment Center, so it is helping that we actually had an expansion.
We did, yeah. We CLIP lost some beds because Nava's closed, and the new cottage San Juan has not opened yet, but they're trying to hire staff, so they will have a few more beds to make up for that loss. So.
All right, and then there were a couple of questions around family-initiated treatment. Is a youth who is in treatment due to family-initiated treatment, do they still have rights to sign or not sign ROIs or release of information for their parents?
They have, yes. I mean, they still have the right to sign them, but whether they're going to be effective due to fit is another question. So again, if there's fit, then the family can have access and can be engaged in treatment as well.
I think just to piggyback off of this, we really didn't discuss this, but I think it's a really important piece that not maybe we in the behavioral health world understand pretty clearly, but in Washington State, the age of consent around treatment for behavioral health is 13 and older. And so children who are age 13 and older can enter treatment of their own free will. They also can decide who has access to their information. So, you know, release of information, they have the right to sign for that release of information. And that creates quite a few challenges, which is why FIT was kind of put into place, is parents who were concerned about their youth and safety around their youth and really wanting to ensure that they had a way to ensure their youth received treatment, maybe even when they weren't necessarily wanting that treatment.
Yeah, and if you want more information, again, there's a lot of great information on the HCA website. It's for providers, there's some for families, so I really encourage you. And again, every agency might do things differently, again, with their own policies and processes, so that's important to know as well. But I really encourage you because it can get confusing, so.
Yeah, okay. And the next couple of questions are around contacting the MCOs. So there was a question on the slide that listed the emails for each MCO. Is that a place where providers could reach out for questions around involuntary behavioral health treatment?
Who wants to take that one? Well, involuntary treatment would be through the Administrative Services Organization or the crisis teams in each county. Is that, I mean, I guess it would be dependent on what the specific question around ITs is. If it's per member, you know, then you could reach out, but I guess I would need more information about what the question is.
I think for any general questions that come up, I think another question that was in the chat, it was asking if there are regional MCO representatives that people can ask follow-up questions to. I would think, I don't want to put everybody here on the spot, but I would think everybody on the panel today would be happy to answer any questions or follow up with anyone if there are other conversations that they'd like to have kind of outside of this webinar. I'm seeing some head nods, right? And then the next question, also kind of around the MCOs, are how are individuals assigned to an MCO?
That's actually done at the healthcare authority kind of level. Individuals can decide who they want to be with, and they can change every month if they choose to. So an individual kind of going onto the navigation on the page can look at different MCOs, look at what services we offer, kind of the overall things. Then they can decide which MCO they want, and they can go with that MCO. And if the next month they decide they don't like the MCO or services that they received, they can change that.
And if they don't choose an MCO, HCA will assign them to an MCO.
All right. And the next question is on ABA again. It says, how can we assist, or can you provide suggestions as to how we can guide families who are interested in ABA services but don't have an autism diagnosis? Sometimes families are told that they cannot proceed with referral because they don't have an autism diagnosis by their provider.
Yeah, I think this is kind of going back to the centers of excellence or the allowable provider types. So in our state, prior to ABA, it is required that they have that diagnosis by either that appropriate credentialed person to do that, licensed person that I went through, or a centers of excellence, a designated centers of excellence. And then from there, they can access ABA services. So it's outlined too in the Healthcare Authority Billing Guide, if you want kind of to take a deeper dive in to look at that.
And all the MCOs have care management teams that can help families navigate the process. So providers could also refer to care management.
Okay, and kind of back to the enrollment question, there was kind of a follow-up to that. It says, do MCOs inform individuals when they enroll in an MCO about behavioral treatment? And if so, how?
Can you repeat that question really quick, Lindsay? Sorry, I was reading one up here that was,
Sure.
I thought it was the question.
It's not. Hard to track them all. It was, do you inform individuals when they enroll in an MCO about this behavioral treatment? If yes, how? So I'm thinking that was related to, do we inform individuals when they enroll about, I'm thinking ABA or it says behavioral treatment.
Probably maybe behavior, what treatment options there are. I think all of the MCOs probably have sort of a similar process. When a new member comes on, that the member receives benefit information, and from that benefit information, it would outline what services they're eligible for with their Medicaid benefit.
And yeah, and I think, letters go out, and it refers to member handbooks and our websites that have a lot of resources. So yeah, they're notified that they are now enrolled with the MCO.
Right. The next one, again, some discussion around the controversy with ABA. A question around, some insurance sees it as autism therapy and denies it if the client isn't diagnosed with autism. What is the stance of the Medicaid MCOs about this issue? So if there's a formal stance from the MCOs on that.
I think we review it through medical necessity. So it doesn't have to be a diagnosis of autism, but it does have to be a diagnosis that is, it's an evidence-based treatment for. Does that make sense? So it is reviewed through our medical necessity lens.
Another question came in through the chat. around tribal affiliation. So if a consumer has tribal affiliation and has an MCO, are there limitations to any of their services? Some families have reported this.
I don't believe so. I mean, they should, if they're enrolled with our MCO, they have the same benefits and eligible for the same resources as non-tribal youth.
I would encourage if anyone runs into this to reach out to us though, because that shouldn't be the
that
case.
Should be happening.
Right. I was going to say the same thing, that it'd be helpful to have an example. I also wonder if some individuals with tribal affiliations have fee-for-service Medicaid and not managed care Medicaid, and the coverage is different. I don't know if that.
Yeah, there was clarification in the chat that this particular situation was around access to birth control.
I'm not aware of that, but I think Dr. Lee, you bring up a really good point. To not all tribal do go through a managed care, that some is through the healthcare authority through a different program, which is fee for service. And I think that is a little bit different. But again, I encourage you to reach out to who the program is with, and if there's an issue like that, so that we can work through it and help the member.
All right, we have just a few minutes left. I'm not seeing any other questions in the Q&A or the chat box at this time, but I think our panelists are happy to stay on until the very end if there are any lingering questions that come in. Just want to take a moment to thank everyone so much for joining us today. If you are kind of logging off, want to get that in and just say thank you so much for joining. And again, please take a moment to complete that evaluation. We do have another question. Can you speak to PHP coverage?
So I think by PHP, you mean partial hospital program. That's not in the Medicaid state plan. We did concentrate on the Medicaid state plan. Some of the MCOs do cover some PHP programs, or maybe we all cover some PHP programs. There are plans by the state to add partial hospital to the Medicaid state plan. So I think there are just some individual differences, some things left over, but it's not something that the state covers on a wide basis.
Yeah, we're working a lot with the Healthcare Authority on partial hospitalization and intensive outpatient programs. That is currently not covered in the state plan. There are a couple of pilots going on right now of these programs that are through the state, and so and we're advocating all the time to ensure that we have a full continuum of care here in Washington State.
Yeah, and then there was a follow-up question, and so again, it'd be great if a member contacts us requesting whatever service they're looking for. It'd be even greater if there's a provider recommendation for that level of care. Again, they have to meet medical necessity, so a recommendation or any kind of psychiatric evaluation recommending that is extremely helpful. And yeah, we can connect them with our care coordination folks, and they can work with the family in accessing services. But sometimes we do not have those providers in our network, and so we need to do single case agreements, and then so it's a bit of a process.
All right, there's another comment in the chat that this is a great opportunity and we need to do this at least quarterly. So I think there was also a question on when the next webinar is. I don't know that there's another one scheduled at right this moment, but great feedback that this was helpful, and we are so glad that you joined us today. So thank you all so much for your time. And again, as you log out today, there is an evaluation that will launch. We ask that you do take a moment and give us some feedback. And I think this concludes today's presentation. So again, thank you so much for your time and joining us on this webinar. And will slides be available? Yes, we will send out the recording link as well as the slides to those who registered and joined today. So again, thank you all so much and look forward to seeing you at the next webinar, whenever that may be.
Thank you.
Thank
Thank
you.
you. Bye.